Good evening, ladies and gentlemen, and thank you for joining us tonight as ASDA Advocacy presents Barriers to Care and Alternative Workforce Models. I will be your moderator. My name is John Vogel. I am the chair of the Advocacy Council. So for the agenda, we have several great presenters, the first of which is going to be Dr. Burton Eldon. He's going to be presenting on public health dentistry. He is a board-certified pediatric dentist and professor of dental medicine and health policy and management at Columbia University. He also has his master's in public health and chairs the population oral health in the College of Dental Medicine. He is a founding director and senior fellow in the public policy at the Children's Dental Health Project, a DC-based organization that promotes governmental policies and programs to improve equity in children's oral health. Our second presenter this evening will be Mikkel Mccrae. She is a community dental health coordinator, and she's been working in private practice as a dental hygienist before that for 16 years. She resides in a small rural town in Arizona called Kima with her husband and 5 children. She was motivated to take on the Community Dental Health Coordinator program after learning that her rural community ranked lowest in the state for children who received dental care in the last year. The program motivated her to leave private practice and enter the field of public health, public dental health. She founded the company Toothbuds, bringing understanding of dental disease to schools, a nonprofit organization. It's staffed by licensed affiliated practice dental hygienists who utilize teledentistry to match at-risk children who lack access to care with a dental provider. And our final presenter for the evening will be Jody Becker, who is a dental therapist. She practiced for 25 years as a dental hygienist before going back and receiving her master's degree in advanced dental therapy in 2014. She was certified after a couple thousand hours in credentialing as an advanced dental therapist in 2016 and currently works for Children's Dental Services as a collaborative practice dental hygienist, in which she provides preventative care in schools and in Greater Minnesota. As a duly licensed dental hygienist and advanced dental therapist, she can provide both preventative and restorative care to those she sees. She's been certified as an advanced dental therapist, primarily provides care to off-sites in schools, Head Start programs, and in Greater Minnesota. At the end of this webinar, we will just kind of wrap up and talk about Advocacy Month a little bit, and we will address questions after each presenter. You can ask your questions directly by typing them into the control panel, which you should see on the right of your screen. At the very bottom, there is a little section that says chat and questions. You can type your questions there, and they'll be answered in the order they are asked. Just as an introduction to this evening's webinar, we wanted to talk about some barriers to care. And barriers to care are anything that can prevent people from receiving the care, particularly dental health care, that they need. The most common reasons for barriers to care include financial hardship, geographic location, whether that's the individual not being in a close proximity to a providing dentist or not having the ability to get to that dentist. Also, pressing health needs often come before pressing dental needs. And then just in general, poor oral health literacy prevents people from getting the care they need because they just don't know that they need the care. And then in the little infographic to the left, you'll kind of see some very striking statistics about dental care here in the United States. 1 in 4 children has caries under the age of 5, and over 180 million Americans will not visit the dentist this year. So why does this matter? Well, across the United States, there's around 5,500 dental health professional shortage areas, which mean that those are underserved areas currently. And more than 16.5 million children in the US were not taken to a dentist. So not only are they not getting care that they need, they're not getting the oral health literacy and education for preventative for the future. So that's a pretty big deal. And what is ASDA's stance on this? Well, ASDA's stance, as decided by the delegates, is that only a qualified dentist should perform the following functions, including but not limited to examination, diagnosis and treatment planning, prescribing work authorizations, performing irreversible dental procedures, and prescribing drugs or other medications. So some of the solutions that ASDA currently supports is the ADA's Action for Dental Health Initiative, the Community Dental Health Coordinator Program, preventative care and early intervention, ER referral programs, and teledentistry. We also support expansion for the Children's Health Insurance Program, increased reimbursement rates for Medicaid, expansion of Medicaid, decreased student loan burden to allow dental providers to more easily go to rural areas and underserved areas without that financial burden, increase health service corps job opportunities for dentists in underserved areas. Whoops, sorry about that, y'all. And encourage increased participation in programs such as Give Kids a Smile and Missions of Mercy and other outreach programs. All right, so with that being said, we'll go ahead to our first presenter, which is Dr. Burton Eldon.
Thank you, John. I appreciate your just trying to figure out how to bring up my presentation.
Yeah, if you'll give me 1 second, Dr. Eldon, I will give you that control. Okay, you should have received the request to take over.
Well, John, I very much appreciate your introduction because the issues you're talking about, barriers to care, inequities, geographic and financial issues, those are the kinds of things that public health dentists get up every day to attend to. So let's see if we can explain what public health dentistry does and how it brings a conviction and a commitment to addressing the kinds of issues that you've just raised. The essence of clinical dentistry, as you all know from wherever you are in your training, is the individual patient, while the essence of public health dentistry is populations. Those populations may be small, they may be large, they may be huge, but the focus is always on populations. So what we do as public health dentists is very much the same as what clinicians do. And as you mentioned, I am a pediatric dentist. I practiced in private practice for over 20 years, but realized as I was in practice how limiting it was to be able to address only one child at a time, one patient at a time. So we bring the very same skills as a clinician, but we look at it a little differently. So instead of diagnosing an individual patient, we diagnose a group or a population and use the skills of epidemiology and biostatistics to do so. Instead of a treatment plan, a clinical treatment plan, the plan is a program. It may be a health systems program, it may be a health education program, but it's a program, and the treatment is the program itself. And then a recall is looking back to see, through program evaluation, how well we did in making things better and learning our lessons to do better the next time. So I wanted to be clear that dental public health is a recognized specialty by the American Dental Association, of which there are 9 such specialties. We are the 7th in terms of size, but as you can see, with fewer than 200 dental public health certified boarded members of that specialty, we are really quite tiny. However, our leverage is quite large, again, because we work with populations. To qualify as a public health dentist requires both a dental degree and a master's in public health or similar degree. Master's in public administration, even an MBA might do the job, but there needs to be a master's level training that brings a number of skills to complement what we learn as dental students. Following that, to become board eligible, one must complete a 1-year residency or fellowship, sit for the board exams, and then when passing those, become boarded in the specialty. And like many of the specialties, there is a recertification program as well. So where do you find us? Well, dental public health specialists work wherever they can get their hands on populations. So many in government, federal, state, and local, in policy and advocacy organizations like the Children's Dental Health Project. Do visit us online, cdhp.org. In academics, doing research and teaching, in foundations and think tanks and business, in the military. But you'll see that I've also added not simply working in a safety net clinic. Many dentists who work in a safety net clinic will reference themselves as public health dentists because they're serving an underserved population. But that is, admirable as it is, that is not what the specialty is about. So we are non-clinical dental specialty, which almost sounds like an oxymoron, but think of the numbers of people who we can reach. There are 10 core competencies that define dental public health. And by the way, the sister specialty in medicine is called preventive medicine, which indicates that strong focus that we have in public health on prevention. But the first, and the one we're going to feature, is population oral health management, managing the oral health of a group, but also ethical practice, systems evaluation, surveillance, communication, collaboration, advocacy, the kinds of things you would expect when working with groups. And so the question becomes, how do non-clinicians contribute to access to care? And there are two fundamental components of population oral health management through which public health dentists do that. The first is by developing and managing care systems, an entire care system. So how does that system provide everything from community outreach all the way up to ensuring comprehensive dental treatment? And the second, which is perhaps even more important, is by addressing the full range of oral health determinants. As clinicians, we tend to forget that only about 10% of oral health comes from clinical care, while the rest comes from things that public health dentistry can attend to. So here you get an indication of that 10%. Whether it's medical care or dental care, health status results from only, is supported only in small part by health care, because health care tends to be remedial. Rather, as you can see on that lower pie chart, lifestyle accounts for half or more. Lifestyle being individual behavior plus social environment, built environment. So those kinds of determinants that are really in the hands of our patients. John mentioned the importance of health literacy in order to enhance our patients' abilities to take care of themselves. But taking care of themselves can also be approached at the population level. So population oral health management is about ensuring oral health for everyone in the defined group by addressing that full range of health determinants, not just clinical care. And that range is clinical, behavioral, social, environmental, as well as biological. So with that kind of global perspective, that holistic perspective, there are specific aims of population health management. And those are to be cost effective and make sure that there's value for the dollar spent on health care. Secondly, that the care be high quality. And thirdly, that the experience be positive. So dental public health is holistic. It approaches all of the health determinants. It also depends on a systems perspective. So the critical question for us tonight is, who can do what, where, when, and how to improve the oral health and well-being for all? There are many components to trying to think through a dental care system. And so I've just provided for you here a laundry list of those components. We're focusing on workforce tonight, so I listed that first. But also, who pays for the care? Where is it delivered? How do we know what was delivered, and how do we know if it was accountable to the patient, accountable to the payer, and of high quality? Did it involve interprofessional practice? Did it integrate with medical care? Was there care coordination? Did it improve equity? Did it depend upon public policies? And did it learn from health services research? But tonight, with a focus on workforce, public health dentists concern themselves with the composition, the training, competency, licensure, and deployment of the different types of oral health workers. So here's an example for you of how we might look at creating a delivery system that works and that provides care for as many people as possible. It starts with political philosophy. Then we have to decide, so this is any nation in the world. But looking at the U.S., what is our particular political philosophy? What's our financing system, and where does the money come from? How do we pay providers? And into what kind of delivery system? And does that delivery system include or exclude oral health care? For just children, for children and adults, for everyone, for whom? So here's an example of how this might play out. Germany has a very straightforward approach to this. It knows that it's a conservative country. It uses a Bismarckian, mostly private payment system. It pays mostly through the private payment system. And it pays a mostly private delivery system, and it does include dental care. But take a look on the right side. In the United States, politically, we're all over the board. We don't know if we're entirely conservative, liberal, even libertarian, and so we have a whole variety of different ways of providing care. Our political philosophy leads us on to an entirely different set of systems of care. So the VA system, the military system, the private system, the Medicaid system, the CHIP system, they're all different. Here's another example of systems perspective that we do in public health. We want to approach public education broadly. So oral health education not focused on just individual patients, but on the entire population. So informing people about water fluoridation, about diet, about oral hygiene, and about early diagnosis and identification of mouth cancers. So a systems perspective involves a whole variety of bits and pieces that have to be sewn together and integrated in ways that actually create an effective delivery system so that providers are happy, patients are happy, payers are happy, and the entire system supports oral health. So it starts with surveillance because we have to know what the problems are and who's got them. Then it goes to coverage because there needs to be some sort of payment for services. Then to workforce to make sure that the people are out there to provide the care. Then addressing those barriers that John talked about. And in the U.S. today, the largest barrier for adults is financial, whereas for children, because of the extensive coverage that they now have, that is not a barrier. Then outreach. As John mentioned, sometimes people just don't know what they need. So reaching out to the population and pulling them up into a system and then providing service, including in federally qualified health centers. So this is the broad approach that public health dentistry takes to trying to address the issues of barriers and workforce. So to recap, public health dentistry focuses on population oral health management. It ensures oral health for everyone within a defined group. That group might be an employment group, an employee group. It might be a geographic group. It might be people who share a common disease. There are a whole variety of ways of slicing and dicing the population. But the goal is to ensure oral health for everyone within the defined group by addressing not just dental care, but also the social, behavioral, environmental determinants of oral health, with the goals of being cost-effective, providing high value to the dollar, whoever is paying for care, whether that's government or an employer or coming out of people's individual pockets, that the whole system should provide high-quality oral health promotion and care, and that the experience should be positive for the individual patients as well as for the population. So what about your future? Well, right now, you're living in a world where dentistry is very much siloed, and we focus on every different provider being disease-centered. What's changing is integrated care systems with person-centered holistic care. So, last kind of take-home here is that population oral health management sits smack at the intersection of clinical dentistry and dental public health. Population oral health management lives at that intersection, and future leadership addressing barriers, addressing workforce, is going to require equal parts public health and clinical skill. Thanks so very much. I look forward to questions. John?
Thank you, Dr. Edelstein, for your presentation. It is now time to ask questions. So if any of the attendees have any questions, you may type them in the bottom of the chat box now. We'll give them a few minutes to let the questions come in. At this time, there are no questions, but I did have one question for you, actually. Can you name a specific initiative that you have worked on within the realm of public health dentistry that is addressing some of these access to care issues?
Oh, thank you for that question. That's a great question. One of our most effective programs at Columbia University today is a project called My Smile Buddy. We've identified 1,250 kids living in the New York City area, all of whom are under the age of 6 and all of whom have early childhood caries. And the question we were asking was, knowing that these kids are at extreme risk of continuing to have tooth decay throughout their lives, what could we do that's a little bit different, that's built on public health principles, that would actually improve their trajectory and make it possible for them to have oral health throughout their lives? So what we did is we identified these 1,250 kids. They're from 950 families, and we signed them up with community health workers. Those community health workers use software called My Smile Buddy that allows them to inform their families about the etiology of caries, determine what the risk factors are for that particular family, identify a goal for that family to pursue, have that family develop their own action plan, and then support the family over the course of 12 months through home visits by the community health worker, as well as having their routine dental care, so that the community health workers help the families reach their own action plans and their own goals. As a result of this, amongst these kids, at the start of our project, so this is a population. The population is defined as kids living in New York City under the age of 6 with early childhood caries. The approach was to utilize community health workers to complement traditional dental care. And the goal was to see if we could improve the children's oral health status at low cost and put them on a trajectory of good health. The results so far are that at the start, 51% of parents stated that their children were in poor or fair oral health condition. And after 1 year, only 2.3% said that their children were in fair oral health. The dentists we worked with reported that the home care that the children were now receiving, the improved diet and the regular oral hygiene with fluoridated toothpaste, was resulting in caries arrest, and that's without silver diamine fluoride. It was resulting in caries arrest so that the kids needed fewer restorations, and we would expect they will have less caries trajectory over time. So that was a true population approach. We defined a population. We defined a provider. We provided that provider with software and iPads that would allow them to stay true to the science. We trained them in motivational interviewing, and we saw that the kids had a marked improvement in their oral health. And the parents' knowledge, attitudes, and behaviors all improved as well.
Excellent. Well, thank you so much for that answer, Dr. Edelstein. There are additional questions, but we want to ensure that we get to all the panelists, so we will be holding those questions for the end. So with that being said, we will now move on to Mikkel Mccrae for her presentation on community dental health coordinators.
I think Jody has the presentation at the moment. Is that right, Jody? And Jody, I think, is on mute.
I have already passed it to Mikkel.
Okay, thank you.
Okay, can you see my screen?
Yep, can you make it big, please?
Let's do it one more time. Here we go. There we go. Can you see my screen now?
Yes.
Are we good? Okay, fantastic. Well, thank you for this opportunity. It's really exciting to be able to join you this evening and talk about the adventure I have been on for the last few years. Just to begin, I do live in a very rural town. My neighbors consist of cows and horses, and there's not a single stoplight in my entire town. It's fun. I love living here. I love being out in the country. But with that comes access to care problems, and I want to get into that. So moving on, I've been in private practice or working as a dental hygienist for 16 years. And as you all do, sorry, there was a pause with that one. I had to fast forward. That screen is bad. I was getting some continuing education courses, and I'm sitting there in the room, and they're talking about how Greenlee County and Graham County have the poorest oral health statistics in the entire state of Arizona. And I was sitting there looking around thinking, I am the only person in this room who even knows where Graham and Greenlee counties are, because that's where I live. And this fire started burning inside me thinking, you know, I've been sitting in private practice waiting for people to walk in my door so that I can clean their teeth. Yet apparently there's all these people out there in my county who aren't even receiving any access to care. So I'm sitting there. I decided it was time. I wanted to make a change. I wanted to do something about these statistics. And someone in the audience happened to stand up and say, oh, and by the way, there's a community dental health coordinator program. And I thought, I'm going to take that program because I know nothing about public dental health. I don't know how to start a program. I don't even know what to do. So I'm going to take the program and see if it will teach me how to help my community. And it did exactly that. So moving on to the slide in front of you, don't be too concerned about what's written on my slides, but more importantly, I want you to see how I transformed from the beginning of my community dental health coordinator program. From a dental hygienist in private practice for 16 years, I knew how to polish, floss, teach people how to brush their teeth, but I didn't know anything about my community and their health needs. So I bring this slide up. This was an excerpt from my scholarship application for the program, and I want to show you how basic it was and where my understanding of what I was actually trying to do was, and then I want you to see how it progressed. So in blue it says, as an RDH, my scope of practice in the state of Arizona allows me to educate students, provide fluoride treatments, and place sealants. I really thought that's all my state allowed me to do. So here is the program. Now, what does a community dental health coordinator, what does the program look like? I bring this up because it was a tough program. However, I could go through this program and work full-time with no problems. I bring that up so that as you go into your dental field and your private practice, if you have a dental hygienist or a dental assistant, this is not a curriculum that you would be overwhelming your staff to participate in. It's challenging, yes, but it's not overwhelming. So look at some of the courses: oral health communication, interviewing skills, legal and ethical issues, dental health and advocacy and outreach. And I want to show you what these programs taught me. So I started going to, for the homework assignments, I started having to do research online. And it took me to programs and data books such as this that I didn't even know existed. And so I'm going through and I'm doing my homework for this course, and I'm researching all about my state. I'm finding out all this information in Graham and Greenlee County I didn't even know existed. Again, another for the Center of Disease Control and Prevention, another pamphlet and booklet, places that I went to learn more about my community. And from that, I learned these amazing statistics that in my county alone, I knew that it was bad, but I didn't know how bad it was because I was blind. I just went to work every day. I treated the people who came in my office and I went home. So look to the bottom, it says both Graham and Greenlee counties have medically underserved populations and lack the dental resources needed to satisfy their populations. First of all, before starting the program, I had no idea what a medically underserved population was. Having gone through the program, I now know that there are 9 dental shortage areas in Graham and Greenlee counties. And I'll be honest, I'm thinking, how is this possible? How is there a dental shortage area in my county when this is what I saw every day? I was sitting in private practice and every day there were lulls in our schedule. So how can we have dental shortage areas where there's more people than there are dentists that need care, yet we don't have anything to do? So I walk in my dentist's office and he doesn't have any patients, so he's playing solitaire. So I bring that up just kind of for fun, but I really want to make a good point. Why is there 9 dental shortage areas in my community, yet my dentist is sitting and playing solitaire because we don't have any patients? There's a disconnect somewhere. So moving on, I began doing more homework and getting deeper and deeper into the health world. I was just a dental hygienist. I was not a dental health advocate. I knew how to clean teeth, but I don't really think I understood dental health. I don't think I understood the disparities that were out there before taking this program. Healthy People 2020 objective for dental visits is to increase the percentage of children, adolescents, and adults who use the dental healthcare system in the last year to 49%. I want you to keep an eye on that. So then I found statistics such as this. I found statistics that the prevalence of untreated tooth decay by county, 34% in Graham County and 38% in Greenlee County. Now look at this one, Greenlee County, where I live, we only have 42% of the children who have visited a dentist in the last year. That is the lowest percentage in our state. The irony, Greenlee County has more children with private dental insurance than any other county in our state. So why are only 42% of the children seeing a dentist? Access to care. There is not a single dentist or dental hygienist living in all of Greenlee County. Moving on, I then learned more, things I didn't even know, that percent of children with dental pain or infection by region. 2% in my county have dental pain or infection. Well, what does that mean? I did my research, I did my homework. There are 8,837 students and 177 of them are experiencing severe dental pain. While I'm sitting in my office playing solitaire, filing charts, there are 177 children out there who are not seeing a dentist, who have and are experiencing severe child pain or dental pain. Moving on, I'm learning more and more. I go to the Children's Oral Health Report for my assignments. I am right next to the San Carlos Reservation, and I'm reading through the Tribal Oral Health Report, learning more and more about my state, things I didn't even know were in my backyard. Problems in oral health that were in my backyard that I didn't know about. I begin reading through there and I'm learning about, look at the bottom, that the San Carlos tribe is trying to get more community dental health coordinators to partner with their local colleges and universities. That's the first time I had actually seen the community dental health coordinator program mentioned anywhere. Furthermore, I was reading and learned that they are looking for affiliated practice dental hygienists to bring preventative care to their community. And I'm thinking, what's an affiliated practice dental hygienist? I think I'd heard it a couple times, but having not gone through this program and learned all of the rules and regulations for my state and what was going on in kind of the public and health end of things, I didn't know what it was. So what is an affiliated practice dental hygienist? And I don't want to focus on this so much, but what I'm trying to show you is how the community dental health coordinator expanded my view of the public dental health world and where that took me and how that's benefiting my community. So an affiliated practice dental hygienist is allowed to provide preventative services without the direct supervision of a dentist in specified areas, particularly a school area, in blue, in a public or private school authority. So I got excited thinking, maybe I can do something like that. Part of the Community Dental Health Coordinator program is you do an internship. Well, I did it at the Boys and Girls Club. This was my first Ryan. He'd never been to a dentist, no dental insurance, mixed dentition with active decay. One of the things we also learned in the Community Dental Health Coordinator program is that you have to speak at the level that your patients will understand. Now, we are licensed and allowed through the affiliated practice model to take x-rays. However, if I send that x-ray image there on the left home with a referral form to go see your dentist, a parent's going to look at that and that's not going to mean anything to them. So having gone through the program, I decided that the image on the right showing the tooth decay to the parent is much more effective at motivating the parent to go see their dentist. Again, something I wouldn't have thought about had I not gone through the Community Dental Health Coordinator program. I would have just sent the image of the x-ray home to the parent, whereas the image on the right is clearly more motivating to somebody who's not versed in reading a dental x-ray, which most will not be, obviously. So you can see I crossed out dental x-rays and did enter oral camera images. So from my internship that I did for the Community Dental Health Program, at the bottom you can see the statistics for my little rural community at the Boys and Girls Club. 86% of the children had active decay, 71% had never been to the dentist, and 14% were experiencing toothaches. Not good statistics, but not surprising considering that Greenlee County does not even have a single dentist or dental hygienist living in the entire county. So what does this mean for you? If you as a dentist get out into private practice and you decide, I need to hire a community dental health coordinator to go out into the community and round up these people and educate these people that do not know the importance of their oral health. If you have 3 community dental health coordinators, and in my case in the state of Arizona, I'm sequencing that to the affiliated practice dental hygienist, we see 12 students a day, and then we refer those 12 students to our affiliated dentist. We are going out in the field, we're seeing patients who have never seen a dentist, we send them home with a referral form, with a picture of what we found, with our dentist, all of their information going straight, so that they can go and get their dentist. We're providing that, we're getting the patients to the dentist. That's our overall goal. They wrote it up in the paper because that's what happens in a small town when there's nothing else to talk about. That kind of brings together what I did. I started a nonprofit organization because in my area, affiliated practice dental hygienists are not reimbursed, and so the only way to get out into the community and help those who needed it was to start it as a nonprofit. I show you this because I want you to see where I was and where I've come to be through the process of going through the Community Dental Health Coordinator program. I now have a mission statement. I now have a vision. And again, why do I show you this? I show you this because I started the Community Dental Health Coordinator program as just a dental hygienist who scraped teeth all day long, who flossed, who polished teeth and did OHI. And now I have a vision. Now I know my community and I'm reaching out to the community and I am getting those people who don't understand the importance of oral health. They don't understand that if you don't take your child to a dentist every year for a dental checkup, a small tiny cavity can turn into a huge cavity and cost upwards of $1,500, if not more, if they have to go to a medical emergency room. People don't understand that problem. They say, I don't have enough money to take my child to a dentist. Well, if you don't take your child to a dentist, then you're really the expenses are gonna go up, and people don't understand that. That's one of the biggest questions and problems we have here in my rural community is parents don't wanna spend I'll throw out a number, the $100. Well, in the long run, they end up spending $1,500 because their child's in pain, and it turns into much more of a problem for the family financially than it would have been if they would have stayed up on their yearly care. So in conclusion, now as a community dental health coordinator, I've reached out to all of these other areas in my community: Arizona at Work, First Things First, Special Olympics, the San Carlos reservations. All of these places we go and do community outreach, and we present and educate the public there at these places about proper oral hygiene and the need for yearly exams and the importance of seeing their dentist. But I want you to jump down to the Juvenile Correction Facility. When I went and spoke at the Juvenile Correction Facility, the pastor there, slash counselor, came up to me and he said, a lot of these kids are in here right now because they had a toothache and it hurt and their parents didn't take them to the dentist, so they started taking drugs to get rid of a toothache. 16 years of private practice, and I had never thought for 2 seconds that a toothache could lead to drug addiction. And so in that moment, I learned so much. So as a community dental health care coordinator, if I go out in the field and I can prevent tooth pain and tooth infection by educating the public and connecting them to a dental provider, which will in the long run prevent even one child from going down the road of drug addiction, then it's worth it. It's absolutely worth it. And so I take that one step farther. As I'm not only a community dental health coordinator, but my efforts to do something for my community, it just explodes into a general overall health and well-being for our entire community. So that's my presentation on tooth buds. And if you have any questions, I'd be happy to answer them. I know I'm kind of all over the place, but I get so passionate about what I'm doing. It's 16 years being a dental hygienist. I never knew how much I could love my job, and it's all because of the Community Dental Health Coordinator program. So I'd love to answer any questions if you have some.
Well, thank you, Mikkel, for your presentation. That was very eye-opening, and even better the second time hearing it. So thank you.
Thank you.
If anyone has any questions, you're welcome to type them in the chat box. And also for the last presenter, you're welcome to type your questions in as she's presenting. We'll hold them till the end, but just so we have some queued up, that would be perfect. So giving the attendees a moment to submit questions. And Mikkel, how long have you been practicing as a CDHC now?
I graduated in August, and so we just actually went into our first school. And out of 110 kids, we got back 87 consent forms. And of those 87 consent forms, we've cleaned their teeth, placed sealants, done fluoride varnish, using a little SDS, silver diamine fluoride as needed. And all of those 87 children who received referral forms to go to our affiliated dentist. So most of those children, I don't have the statistics in front of me, had never been to a dentist before. They did not have an established dentist. So our affiliated dentist now has, I'm guessing, at least 50 new patients in 3 weeks, simply because we reached out to a school where dental care was not utilized, if that's the best word. It wasn't seen as important, and we're making a difference. I've gotten such positive feedback from parents. You know, my kids are actually brushing their teeth. I have to fight them every night, and now they're coming home. They want to brush their teeth. We use the fun disclosing solution, and there's nothing more motivating to a child than to see pink fuzz all over their teeth. They want to get it off. It's the most motivating thing ever, and so we're making a difference. It's fantastic.
Awesome. Well, thank you. So we do have a couple more questions, but since we're running right at time, we'll go ahead and let Jody Becker give her presentation, and then we will answer all the leftover questions at the end. So, Ms. Becker, if you'd like to take it away.
Okay. Can you see my screen?
I can. Is there any way to maximize it? Or do presenter mode?
How's that?
Perfect. Thank you.
Okay. So I am Jody Becker, and I have been a hygienist for 25 years. And after 20 years is when the legislation in Minnesota passed in 2009. And I enjoyed being a dental hygienist. I still enjoy dental hygiene. I just felt like I could do more, that I had more to offer. So when the legislation passed, it took me a little bit to get ready in my personal life to go back to school, but that's what I did, and graduated in 2014 with my master's degree, and master's degree in advanced dental therapy. And I have been working with Children's Dental Services since 2011, first as a dental hygienist and now primarily as an advanced dental therapist. But with the dual license as a dental hygienist and an advanced dental therapist, I've got two scopes of practice, so I can do preventive and restorative care for the kids. So Mikkel was talking about how there are dental provider shortage areas. We have a lot of that in Minnesota as well. And there are areas where there are no dental providers. I take mobile equipment into those rural areas and provide restorative care. And with a dental hygiene background, I do a lot of education and preventive services as well. So this is things that I do in other areas where there are no providers. I've had parents drive 2 and 3 hours to get care for their kids. So big question is, what is a dental therapist and what can we do? A dental therapist is not intended to replace a dentist or take patients from a dentist. That's one of the challenges in getting this legislation passed. Is that was the fear, and that's not the case at all. The dental therapists, Minnesota has in the legislation that we have a certain criteria for the patients that we see. The patient, low income, state insurance, health provider shortage areas. So there are specific criteria that at least 50% of our patients need to qualify in order for us to see them. A dental therapist, advanced dental therapist scope of practice, there are some slight differences. A dental therapist can do fillings in both primary and permanent teeth, the back teeth and the front teeth. Both the silver fillings, I can talk to you guys, and this is a very basic presentation, but both the amalgam and the composite fillings. We do crowns on both permanent and primary teeth. We can do space maintainers, pulpotomies, extractions of primary teeth. As an advanced dental therapist, we also can do extraction of permanent teeth that have class 3 or 4 mobility. We also do assessment and treatment plannings as advanced dental therapists. Right now in Minnesota, advanced dental therapists do not write prescriptions, but we do have the ability to dispense medications. There are 2 training programs in Minnesota. A dental therapist will train for 18 months at the Metropolitan State University program, and in order to be accepted into that program, you need to have a bachelor degree in dental hygiene and be a licensed dental hygienist. When you finish with when you finish with the program, it's a master's degree program. I'm just noticing this says not required by legislation, but the master's degree is a requirement for becoming licensed as a dental hygienist. The University of Minnesota has the other program, and they initially started with just a dental therapy degree program with either the bachelor degree or the master's degree. As a dental therapist, you do not need a master's degree, but to be credentialed advanced, you do need the master's degree. But this fall, all of the students that are entering into the University of Minnesota program will graduate dually licensed. So they've changed their program to include a dental hygiene degree and a dental therapy degree at the same time. And the dental therapists are trained to the same level of a dentist within their scope of practice. So as a dental therapist, our scope of practice is not as broad as a dentist, but we have the same level of training for the procedures that we do. It's a very intense program, and some of the coursework is the pharmacology, pediatrics, epidemiology, and research. We have, during the program, we complete 800 practicum hours over the 18 months, and then we complete a final capstone project before graduation. I attended the Metropolitan State University program, so I did not need to do the dual license because I'd already been a hygienist. For the testing to get licensed, there's not a written board exam for a dental therapy license, but we do the credits exam, and that is given over 2 days. The first day is on a mannequin, and we do 4 different procedures, including a pulpotomy, a stainless steel crown, and crown preps for both anterior and posterior teeth. The second day is clinical testing, and we do the testing right along with the dental students, and we do the same procedures that the dental students do for the board testing, the class 3 filling and a class 2 filling. For the certification, so when you initially become licensed, you're licensed as a dental therapist, and then you go through this process to become credentialed as an advanced dental therapist, and that adds a few things to the scope of practice, and it also changes the supervision level. The dental therapist has many of the procedures are done under direct supervision in a clinic with the dentist, and as an advanced dental therapist, everything is done under general supervision. So the Minnesota Board of Dentistry requires documentation of 2,000 hours of clinical work as a dental therapist, proof of your education, proof of passing the credits exam. And once you have all that information, you submit that to the Board of Dentistry, and then there are 3 parts to the process of becoming credentialed as an advanced dental therapist. One is a records review where you send in charting and x-rays, before and after x-rays of specific procedures that they request. And there's a multiple choice question exam, written exam that's taken. And at the completion of those 2 things, then you get scheduled for an oral interview with the Boards and Licensing Credentialing Committee, the Board of Dentistry. This is a map showing the different areas. The tan area those are the areas that are designated as health provider shortage areas. So these are areas where there just aren't enough providers, or access to care is really challenging for people. A lot of these areas are areas that I travel to with the mobile equipment and provide care for a day or 2 in those areas. So the markings on there are showing the areas where the dental therapists and advanced dental therapists are working in Minnesota. There are no areas right in the metro area that are designated according to this map, but there are health provider shortage areas right in the Twin Cities metro area. That's where Children's Dental Services is based out of, is in Minneapolis. But you can see we provide care in many areas, although we've got up on the the Iron Range up in Duluth, all over the state of Minnesota are areas that we go to, or we have staff in those areas. So, so I guess I'm part of the workforce that is out there doing my best to make a difference, to access care. And when you have a 3-year-old, thank you for taking an infected tooth out. That's pretty powerful. So I can say I'm very, very satisfied with the career that I have and the difference that I'm making for the populations in Minnesota. So now I have to figure out how to get out of this. Get back to, there we go. So I am ready for some questions.
Oh, okay. So we have, if anyone has a question, go ahead and submit it now. We have a very short, we have about 3 more minutes until we're automatically kicked off the webinar. So we also understand that there may be some unanswered questions, and we apologize. We had some really great presentations today that elicited a lot of questions. If you would like, you're welcome to email the Council of Advocacy, and we will get those questions sent out to the presenters, and then we will return responses as well. And Jody, if you could real quick, could you make me the presenter again? Thank you. So just real quick, y'all, just as a reminder, it's Advocacy Month, Go November. We have a couple competitions going on, including the Engage competition. This is going to be a national competition, so whomever wins that, whichever chapter wins that, we have a trophy, and for that one we are doing, sorry, I'm having a mind blank. For the Engage competition, we're doing, we are doing a trophy. We also have a Populist chapter competition, so for whatever social media images you post, whoever gets the most likes, that chapter will win a prize. We'll be announcing those prizes in more clarity coming up. And then, of course, y'all should be seeing the Molar Bear popping up in your social media. So we highly encourage y'all to take pictures with the traveling Molar Bear and hashtag that, hashtag ASDA Advocacy, hashtag Molar Bear. And then we have an individual competition, which is the cartoon, political cartoon competition. So the theme of that is student debt. So submit your images that are related to student debt, PC please, and whomever wins that will be published in the ASDA's national magazine, Contour. You'll receive a framed copy of your cartoon, and then you'll also receive a $100 gift card. So that's great. So we encourage everyone to participate. We have, well, we're just about at the last minute. Were there any questions, Stephanie, for Jody? Okay, so one question. I know there's a lot of pushbacks, and this is for Jody. I know there's a lot of pushback from dentists against the dental therapist model. Do you think this is the perspective from the hygienist about the, do you think the perspective from hygienists is different regarding this model?
I think that, well, it varies. I think in general, I think hygienists are excited about it. Hygienists, it's an excellent career opportunity for hygienists to move to the next level and provide restorative care as well as the preventive care. So I think there are always challenges with some, but I think in general there is a lot of support from the hygienists.
Excellent. And Mikkel, would you like to throw in your 2 cents since you're also a hygienist? Well, maybe you can type something up and we'll send that out. Or I think you might be on mute still.
I was. I have 5 children, as you mentioned, and they keep coming to my door, so I muted myself. No, I think it's wonderful. Anytime you can better educate yourself and find the passion for what you're doing, you need to follow that. You know, in my case, we don't need more dental providers in my rural areas. We need more patients to be connected with providers. So in my area, it works for me and our community to connect the patient to the providers that we have. Dentists don't need to be playing solitaire. They need to be doing what they were trained to do. And so I'm reaching out. In her community, where clearly there is a large area where more dental providers are needed, it just depends on the location. And again, anytime you can better educate yourself and find the passion for what you're doing and serving those in need, it's a good thing.
Well, we are just at time, so I want to thank all of our presenters this evening, Mikkel Mccrae, Jody Becker, and Dr. Eldon. Thank you all so much for presenting on this webinar. We really appreciate it. And again, to any of the attendees, if you do have any questions, and for those questions that were unanswered, you can email them to the email address that is on the screen, advocacy@asdanet.org, and we will ensure that we get those questions answered. So again, thank you all very much for joining us this evening, and have a great night.
Thank you.